Hey everyone, and welcome to another episode of Stronger with Time. I'm your host, Tony Battaji. In today's episode, I sat down with Dr. Nadya Chami. Dr. Chami is a specialist obstetrician and gynecologist who now exclusively works in menopause gynecology. She graduated from medical school in 1999 and then completed her specialist training at the Royal Hospital for Women in Sydney. She now works in private practice in Sydney's eastern suburbs, operates from the Prince of Wales Private Hospital, and lectures medical students at the University of New South Wales and Notre Dame. Dr. Chami also works in the public system at the Menopause Hub located in the Royal Hospital for Women, which is a multidisciplinary team focusing on complex menopause patients. In today's conversation, Dr. Chami and I discuss what menopause gynecologists actually do with their patients and how they arrive at their decisions and recommendations, which is eye-opening, as social media is full of blanket statements made by doctors who actually don't see patients, but leave many women confused because of the clickbait, controversial material they offer. We discussed why menopausal hormonal therapy might be considered, when you would start, when you would stop, the role of testosterone in women's health, and all the other questions you should be asking when considering estrogen and testosterone therapy. What impressed me the most about Dr. Chami's answers was how patient-centered she is when taking the history and the background, the goals and the contraindications into consideration before working with the patient to make informed choices for their health. I learned a lot from this chat. I hope you do as well. So without further delay, please enjoy my conversation with Dr. Nadya Chami. Hey Nadya, thanks for joining me.
Good morning.
I have been wanting to have this conversation with you for some time because this podcast is really all about women's health and fitness, and most of our guests have been experts in the world of physical performance and nutrition. But when it comes to women's health around menopause and after menopause, we really need somebody like you to talk about what is happening and what options you are giving women as they approach menopause, go through it, and then in the years afterwards. So I appreciate you giving up your time today.
It's my absolute pleasure. This is what I talk to women about every day. So it's nice to reach a few more people out there as well.
Why don't you tell us about yourself, what your training is in and what you do all day, every day? Because I think, by contrast, a lot of the misinformation or advice that confuses women available on social media is coming from people who actually don't see patients. They may well be doctors or have PhDs, but they actually don't work with people in the real world. And as I understand, this is all you do is work with patients. So tell us more about yourself.
Yes, well, that's exactly right, Tony. I'm a clinician. So I'm an obstetrician and gynecologist, and I have a special interest in menopause, and I work both in the private and the public sector in Sydney. But a few years ago, I realised that my basic obstetrics and gynecology training just didn't cut it when it came to menopause health advice. And so I did a bit more of a deeper dive. And so a lot of my training is self-taught or information that I've sought out over the years. So, so what I'm doing over the next little while is giving up the obstetrics part of it, which means no more babies to deliver at 2 a.m. and focusing just on my gynecology and menopause in particular. So, that's what I do. Clinical
and
first.
What are the ages of women that you see? Is it primarily just around menopause, or do you see women's health issues full stop?
So I would say these days, about 60% of my practice is menopause, and about 40% would be gynecology of all ages, women of all ages. Even just within the menopause healthcare, I see young women as well as women who are of typical menopause age and postmenopause, because menopause is varied. And although we talk a lot about average age of menopause being 51, and there are some people who are going through menopause early, whether it's because of surgical treatments or some genetic issues. And so even the menopause care is quite varied when it comes to the age groups.
Start by understanding a bit of the history of options for females approaching and going through menopause. And let's start with this phrase, hormone replacement therapy, which was used for many years, but now is no longer used. Can you give us a little bit of a history why the name change?
I think it was a shift in focus from menopause being an illness to really wanting to embrace menopause as a normal part of life and a normal transition. And so that's where I think the name change came from. And I think the focus for women has been away from treating it like a disease, because, of course, all women or all people born as female will go through a menopause when their ovaries stop working for whatever reason. So it has to be considered a normal part of life. So I think that's the very subtle nuance in the difference between replacement and therapy. So, replacement suggests that you're lacking in something, or you're less than, because you have to replace or improve something. But hormone therapy is I think, a better term to suggest that it's an option to treat various conditions or various symptoms that might come with menopause.
Are we using the term MHT or just MT? What do you use in the clinic when you're giving these options to patients?
So I'd like to say I always used MHT, but I often interchange between HRT and MHT just purely because I was taught to use HRT. So I interchange them, and I hope that isn't too confusing in this recording today as well.
I think most people realize that HRT has been used for so long, and despite the well-intentioned change, many of us, or when you're reading literature, it still uses those terms, and I hope we can be forgiven in slipping between those two words.
I will slip, that's right. Hopefully not too confusing.
Why might a woman even consider menopausal hormonal therapy?
Yeah.
What is the option? So when a patient comes to you and says, I am this age and I'm experiencing X, you place a number of different options on a table. And why would they consider hormonal therapy versus not taking it?
Really, there are two main reasons to take MHT. The first is probably the biggest and the most well-known is that women are experiencing symptoms. And the second is that you may take hormone therapy in the form of estrogen to promote your bone strength or to treat weak bones, otherwise called osteopenia, which is a mild weakness in the bones, or osteoporosis, which is a severe weakness of the bones. And these things increase our risk of fractures as we age. So not as many women know about the use of hormone therapy to improve bone strength, but it is being used more and more these days for that reason. But yeah, the first reason is the most common reason to consider the hormone therapy, and that's for symptoms. And there are many symptoms, and a lot of your listeners probably know all of them as we talk about them if we want to go into them in detail.
Many of my clients who I've had for over 2 decades, I've gone through the menopause transition with them. And now as they're approaching 70 and early 70s, almost none of them took hormonal therapies because they were afraid of breast cancer. Could you perhaps speak to why that was a thing for that generation, whereas the modern generation, all of the wives of my best friends who are around 50, they want to take it like it's candy. So what has made this change in a medical opinion on being advised against it versus it is now a viable option?
Well, the pendulum is swinging back again. So before the early 2000s, women were taking hormone therapy like candy, and it was thought to keep women young forever, and as well as being a panacea to prevent all sorts of health problems, including heart disease, because there were some studies looking at improvement in heart health outcomes. And then it went all the way to the other end of the pendulum, and everyone stopped it. But the reason why was because a great big study came out in 2002. Called the Women's Health Initiative, and this study was the largest of its kind with 16,000 women in it, and it was a study out of the US that looked at, it was a randomized control trial, the best type of medical study to see if a medication works or an intervention works, and they looked at using hormone therapy in women to see if it had benefit on other health conditions like heart disease, bone health. They also looked at outcomes like breast cancer and strokes. So what happened was that study was terminated early at only about 5 years because they did an interim analysis and found an increased risk of breast cancer in the women who were taking the hormone therapy. And this overnight caused a massive decrease in use of HRT because there were a few things that led to this massive decrease, and the one main thing was that the media did not know how to to interpret the statistics and to interpret the findings, and was coming out with really amazing headlines saying, stop your HRT, it's going to give you cancer. And of course, women were frightened and stopped their HRT. So there's a whole generation of women in that group, and they're those clients of yours that are now in their 60s and 70s and are very reticent to take HRT. So that it was the WHI that mainly scared women off taking it. But since then, it's been re-examined by many, many other researchers, and the actual increase in breast cancer was much lower than originally stated. Even using the HRT they used, it was an extra 8 cases per 10,000 women using the HRT, and it only became apparent after 5 years of using it. So it was a small but real risk that they saw, but it was very small. And the biggest problem was they only used one type of HRT, and they used an HRT that we very rarely give these days. And I certainly have never prescribed this HRT. It's an old oral estrogen that is technically natural, but it comes from the urine of horses, of pregnant horses, and it's mixed with a progestin, which is the other female hormone, which is synthetic. And we just don't use this. So since then, a lot has changed. And I suppose if we're being positive about this study, it did make us re-examine our reasons for using HRT, and it did spark a lot of interest in the nuance of what types of hormones and how do we give them and what doses and who should get them. So I think we could thank the WHI for casting a spotlight onto HRT use, but it's the main reason it all stopped back in 2002.
And fast forward 23 years, different forms of estrogen, different combinations have now been used, different age groups starting earlier as opposed to later. Where are we now at in terms of its benefit for women who do want to go down that road?
So the main reason and the main benefit still is symptom control. So all of those symptoms that women complain of or may complain of, because only 80% of women will have symptoms, and only about 25% of women will have significant symptoms. But the sorts of symptoms women may describe are things like hot flushes, or the vasomotor symptoms we call them, hot flushes and night sweats, waking up in a pool of sweat at night, having disrupted sleep, and changes in mood swings or anxiety, sometimes depression. Brain fog and forgetfulness is a big one, as is fatigue, and other symptoms like joint pain or muscle aches. So, and the list does go on for more symptoms, but we are using it more for these symptoms, as I said, bone health. But when it comes to preventative health, it is still not considered medication to prevent other long-term health concerns. The studies are not yet strong enough to tell us that we should take our HRT to prevent heart disease or to prevent strokes or dementia or other sorts of cardiovascular disease. So this may come in time as more studies are done, but a lot of the studies we have to make our decisions are made on these older types of hormones, which are a little more problematic, where they're on estrogen that is horse's urine and oral, which has its own issue, and they use synthetic progestins. So what we'd really need is some more studies looking at the body-identical hormones. And that's what we're focusing on more these days when we're prescribing. We're using estradiol, which is a body-identical estrogen. And body-identical just basically means that it's identical to the hormones that are made in a woman's ovaries, but it is made in a lab, but it's chemically the same. So now HRT is using these more natural types of hormones, and we can give it still as a tablet when it comes to estrogen, or we can give it as a patch or a gel, because when we use estrogen through our skin, it actually is a bit safer. Estrogen as a tablet goes through the gut, goes to the liver, and promotes some clotting factors, and this can increase the thickness of our blood a little bit and increase our risk of clots that might be in the veins in our legs or in our lungs, or complicate heart disease or strokes. And so the tablets increase this risk a little, but the gels and the patches do not increase that risk at all. So it is a safer type of hormone therapy, which, especially if women have any risk factors for those conditions, we should be leaning towards.
When you are working with a patient, what are some of those considerations that you would lay out for them in terms of what's your family history risk and so forth? Because you've mentioned you can use it for symptomatology and the jury is still out when it comes to some of the major adverse events with cardiac disease and stroke. What are you looking at when you're making a decision offering these options to your patients?
Yeah, care really does need to be individualised, and that's important to stress because there's not one size fits all with menopause health. And a menopause consultation takes a long time. It is challenging because in primary care in this country, the way it's structured, GPs don't have a lot of time and they're under immense pressure to provide care. So this is a challenging area of medicine. But you'd always start with a full history of the patient's symptoms, their past medical history, family history, is at increased risk of cardiac disease or clotting disorders, strokes, diabetes, everything, as well as their lifestyle factors. And that's always a big, important part of the history. Do they smoke? Do they exercise? What's their exercise routine? What is their diet like? Is it deficient in any particular nutrients? And what's their alcohol intake? So all of these things go into looking at risk factors of lots of conditions, whether it's cardiovascular disease or just baseline breast cancer risk. And then we can sort of target therapies to those concerns, because the role is not just to give hormones, but to give advice that may include hormones, but it may also include lifestyle medicine options to do with exercise, prescription, or dietary advice, or minimizing exposure to toxins like smoking and alcohol. But I mean, that's the history part of it. And then when you see a woman at the time of menopause, it's an opportunity to take a full medical, to do a full examination, but also update her screening tests, because you need to do things like a mammogram to check for screening for breast cancer, and you need to think about whether she should be having bowel kits to look for look at screening for bowel cancer. Is she up to date with her pap smears? And is it time yet to do a bone density if she's got some risk factors there for weak bones? So this is all part of a menopause health assessment. And these are the things that really, really do point me in the direction of what I need to use. Because my first thing is, whatever she's coming with, will I think estrogen help her? Because it's usually estrogen, the hormone that we mostly will find improve symptoms like the hot flushes and the mood and things like that. But do I think it will help? And if I do think it will help, the next biggest thing is, does she need progesterone? Because if a woman has a uterus still, then she must have progesterone, because in the normal menstrual cycle, estrogen and progesterone is in balance. One follows the other. And so a lot of estrogen stimulates the lining of the uterus, and that can over time, if not prevented, can cause abnormalities in the lining of the uterus and also cancer of the lining. So we must, if we have a uterus, take estrogen with progesterone, which thins the lining and prevents that from happening. So that's called endometrial protection, and that is the biggest first decision to make when using HRT. But then, the next decision is, can this woman have her estrogen as a tablet, or should I give it to her through her skin? And that's where those risk factors come in for cardiovascular disease. Is she a smoker? Is she overweight? Does she have high blood pressure? Does she have a strong family history? Does she have diabetes? Any of these risk factors for heart disease would lead me to giving her estrogen through her skin.
And are there any scenarios where, based on your examination, you would just say you're not a candidate?
So I think there is less and less absolute contraindications these days, which means absolutely not. These days, we move more to a shared decision-making model when it comes to risks and contraindications, but there are things we could call relative contraindications. And some of those are things like breast cancer that may be a hormone receptor positive breast cancer, meaning that the cancer cells have receptors to estrogen or progesterone on them, and that taking hormone therapy may stimulate or promote some leftover tumor cells and promote a recurrence of their breast cancer. So that's probably the most well-known and the biggest relative contraindication. Another one might be if a woman currently has uncontrolled cardiovascular disease, if she's been recently getting chest pain or has recently had a heart attack or a stroke, or if she has an active clot in the lung or clots in the legs and it's not quite under control yet. They're the ones that are more likely to be a contraindication, at least initially. So, and then of course an allergy to a medication, but that we often don't see a lot of allergies to these body identical hormones. And there are a couple of liver diseases that we might not want to give hormones as well. So it's a small list, Tony, that most women can have hormone therapy.
So let me ask two follow-up questions. And the first is, way before randomized controlled trials can be done on large scales to observe risk or benefit, do you see a trend in your patient group who you would follow for many years in terms of treatment with MHT and reduction in risk factors for insulin resistance, metabolic disease, cardiovascular disease?
Yeah, we do. We do see it. The studies do show that the use of estrogen early in the postmenopause life decreases cardiovascular events. If you take estrogen within 10 years of your last menstrual period, which is your menopause, that you will decrease the chances of heart attack, of ischemic heart disease, of stroke. So while it's still not recommended to use it just for that reason, studies do suggest that it's helpful for heart health. But the studies are very clear that after 10 years post-menopause, that there is an increased risk in these conditions. And so the idea is that there's a bit of a preventative component to using estrogen for heart health, but that if there is already some existing early heart disease or early abnormalities in the blood vessels, that the use of HRT may actually worsen those conditions and causing more heart disease and strokes. And that's shown in the literature.
Do we know why that is the case?
I think there is the idea that if you have, so a lot of the studies are done in animal models, but the idea is that if you have healthy arteries, that estrogen is likely to be promoting health, promote or preserve your healthy arteries, because estrogen has been shown to relax the arteries. It helps with the endothelial function, which is the lining of our arteries. It does help with improving cholesterol. It does help with our insulin resistance, or decreasing our insulin resistance, or increasing our insulin sensitivity, or helping with our sugar control. So all of those factors go to promoting and preserving the health of our arteries. But then if it's too late and we already have some disease in our arteries called atherosclerosis, with hardening of the arteries, maybe narrowing of the arteries, then it's shown that the estrogen, at least in the old types of estrogen they used to give, that it might promote clotting on top of these narrowed arteries and therefore worsen their function, because there's less blood flow and less ability to do their job. So it's about whether or not there's already been some atherosclerosis. That's the idea behind the primary prevention as to secondary prevention.
And then if one really did want to take estrogen in their 60s for their effect on bone or perceived effect on brain, could you then do a full cardiovascular makeup with imaging to detect the presence of narrowing of artery walls and so forth?
It's a really great question, and we don't have a lot of studies showing what happens when we start estrogen in body identical types forms over the age of 60 or post 10 years post-menopause. So without great evidence, we need to be careful. And I think that's exactly right. We need to look for cardiovascular disease. We need to do things like coronary artery calcium scores, looking at the calcium in our arteries of the heart, which may show some blockages. It means that we need to aggressively manage risk factors like smoking, weight, cholesterol, hypertension. And if we can find risk factors, many of us are open to using estrogen in this age group if we think there's a documented benefit for that woman. So if she has osteoporosis or significant osteopenia, then I would consider it. And also if she still has severe hot flashes, because some women never stop hot flashing only, and they're in their 80s and they can't get off the estrogen. But if they're one of those women that you mentioned that was scared off back in 20 years ago, and then now they're 65 and they're saying, well, I've been hot flushing for 12 years. Can I have it now? Because I'm still waking up at night and I still don't like it and it still bothers me. Then yes, I think a full assessment of her cardiovascular risks first, and then consider if the estrogen is a good idea for her based on how much the symptoms are affecting her and what her bones are doing.
That's a really helpful perspective, Nadia, because this idea that I think is endemic in medicine is that after 65, you will not be offered this as an option because of the pro-thrombotic factors. And with a good makeup and a good imaging and a life history of exercise, and you could then make an informed decision, as you said, with a patient to decide whether this is an option. And I actually do have a client with DEXA scans who is one of these people at 62, started estrogen, and the trajectory in bone change was dramatic because we've got years and years and years of DEXA because she made that decision with her doctor.
Yeah. And I think it is all about that individualized care, Tony. You need to look at the woman in front of you and not have blanket rules for hormone therapy. You do need to individualize it.
Now, I've got a really interesting question here, Nadia, and that is, what happens if somebody is getting benefit in their mood and their bone and all of their symptoms, and they want to stay on MHT forever? Is this something that you would let them do, or you would need a discussion, or you would try and wean them off it? Where do you sit with that?
I think it's one of those shared decision-making opportunities. So you do need that discussion to look at why they're using it and the need for it. Often in practice, we often consider the age of 60 as an arbitrary time to consider weaning off hormone therapy, but I would do it slowly and reassess what's happening as we wean down. I would not do that if a patient had osteoporosis because there's proven benefit for her staying on her HRT. But if she didn't have osteoporosis and was using it for symptoms when she went through menopause, and now she's 60, I would say, look, we could just wean you off and see how you go because you may not need it. And so I do trial it if a patient's open to it. But if their hot flushes come back or mood changes come back, I put them straight back on it. And I have a very low bar to restarting it when we do trial coming off it. And this is supported by the formal menopause societies around the world now. They did change their position a few years ago where they used to say maximum of 5 years, and that came from that WHI study. But they changed their position and they say that there is no general age or rule for a woman to stop HRT at any age, and women that continue to have bothersome symptoms that affect their quality of life can reasonably continue their HRT. You must look at what HRT they're on, because as we get older, we do accumulate more risk factors for other cardiovascular disease and stroke, and we shouldn't be using HRT or estrogen that is oral beyond the age of 60. So even if a woman's really fit and healthy in her 50s and we've thought that oral estrogen is an option, I would usually change her to a transdermal option at the age of 60. And Livial is another example. Livial is a funny kind of combination hormone therapy that has an effect on estrogen and progesterone and testosterone receptors, but it increases the risk of stroke. So as a woman ages and her natural risk of stroke goes up, I would consider that to be contraindicated and would prefer that she be on a transdermal estrogen option.
Very helpful. Do you have patients who, for whatever reason, maybe scared off because of their mother, or they've just heard, but they do not want, they're adamant that they do not want hormonal therapy? What options then do you give? Do you try and use other precursor hormones or supplements? What options are there for women who don't want to go down the hormonal therapies to control vasomotor symptoms?
Well, vasomotor symptoms have been well studied since the WHI scared everyone off their estrogen. So many therapies have since come out that are non-hormonal. So we do have a few options that are evidence-based to offer women. There are some that are antidepressants. So some of the SSRIs and NSRI type antidepressants like venlafaxine, for example, have been shown to decrease the severity and the frequency of hot flushes. So that is an option for a woman who doesn't want hormones. There's also medications like gabapentin, which is a medication used for chronic pain, but also can help hot flushes in many women. There's also really old medications like oxybutynin, which is an old tablet we give for women who have overactive bladders. But when we take it at night, it can decrease night sweats in some women. So there are lots of medications that have been used for a long time that can have an effect on hot flushes, not as well as estrogen. Estrogen is still the best treatment for hot flushes in terms of success. But these other ones may have a place for a woman who decides not to or can't have hormone therapy. There's also a newer one on the market. There's only one in Australia, so I won't say the brand name. We're not allowed to do that, aren't we? It's called, but the drug name is called fezolinetant, and it's a new type of medication that acts at the level of the brain to decrease hot flushes, and it is almost as good as estrogen. It should be used with caution. It's new, so there are studies showing it helps with relatively good safety data, but it's new. And some of the studies did show some small percentage of women had some liver function abnormalities on it. So if anyone is thinking of doing that with their doctor, they do need to watch their liver function. But it is a very effective drug.
How often are you prescribing non-hormonal therapies around menopause?
A lot, because in our clinic, we, at the Menopause Hub, and we might talk about that later, but we see women with complex symptoms or women who can't have hormone therapy because they're actively going through the treatment of some of those conditions we mentioned earlier, like cancer and cardiovascular disease. So we use them a lot.
Let's now talk about preventative hormones. And you've mentioned it's based on symptoms. And if you start it slightly earlier, there seems to be benefits for cardiovascular disease. There has been a viewpoint raised that you can start even earlier than symptoms, potentially by looking at follicle stimulating hormone. And when that starts to increase above a certain number, then you start a early therapy and then transition into menopause. Where do you stand on early treatment?
I do not believe in early treatment without symptoms unless a woman is actually going through premature ovarian insufficiency or early menopause. So POI, or premature ovarian insufficiency, is when a woman has her ovaries are starting to fail before the age of 40. And early menopause is when this occurs before the age of 45, just for definitions. And in those conditions, there is proven benefit to using hormone therapy to prevent conditions like cardiovascular disease, heart attacks, strokes, diabetes, anxiety, depression, dementia, you name it, osteoporosis. So we really want to promote hormone therapy when women are going through menopause early, less than 40 especially. But if you are still having a menstrual cycle that's regular and normal, and your hormones are still in the normal range, there is no data to suggest we should take hormones early for health preservation. However, I do still think we should consider it if that woman turns up with regular cycles and she has symptoms that may be hormonal. So the biggest group I see who are denied hormone therapy are women who are perimenopausal. They may be 45, 46, still having cycles, maybe even a little bit earlier. So their hormones are technically normal. You'll do their blood profile, they'll have normal levels of estrogen, but they have significant mood changes. And there is some work, especially being done in Australia by psychiatrists in Melbourne at Monash University, that looks at perimenopausal depression actually can start before there's any cycle irregularity. So my answer is that no, I don't think it's a good idea just based on a blood test. But if it's early menopause or if there's symptoms, then it should be considered.
And what symptoms would you put into that basket? Because I think this is where it can be really confusing. There can be headaches, there can be sleep disturbance, there can be changes in libido. How do we know whether it's just life stress or whether it is something to have a conversation with somebody like you about?
It's really hard to know the answer to that question before you go through the steps, I think. And most women, by the time they get to me, have already tried some other things. But looking at your lifestyle factors, looking at your sleep and your routine and your exercise and your diet and your smoking and your alcohol, looking at all of those things and seeing where improvements can be made. But if you're still getting symptoms that you think might be hormonal, then considering a trial of hormone therapy. So it might be that I only know the answer to that question after I've tried a woman on hormones for 4 months or so, and we look at what's improved or what hasn't improved to be able to get some clarity. So especially when it comes to mood, because mood, of course, it can be affected by so many things. It can be our hormones, but it can be our lifestyle, and it can be our relationships, our work, stress, our brain chemistry, our history of trauma. Mental health is so complicated that it's hard to know in advance if it will help, but I think we should be open to trialing it. If a woman, especially if she has mental health issues, we should consider hormone therapy if her mental health is worsening in the perimenopause.
How do you even know how much to give? Is it a standard prescription? You mentioned doing it for 4 months to see if there's improvements. I know some women who've tried combinations and they felt schizophrenic within a few weeks, and then they changed the combination, and then it was all back to normal. Is there a lot of trial and error in getting the hormones right?
There really can be. It's not a one-size-fits-all, and I would usually start a little slowly and build up. Um, if you start high hormones quickly, you can get some severe side effects. They might not be dangerous complications, but if you go from relatively low levels of estrogen to high overnight and have high doses, you will probably get headaches. You'll probably get nausea. You'll get fluid retention. You'll get breast soreness. You will hate it. And you will probably think hormone therapy is not for me. So I think, being a bit more gentle and not just thinking, hey, HRT is great, I'm just going to have a high dose of it and it'll make me feel even better. So my approach would normally be to start slowly and increase it over a month or two, and then pause at maybe a medium dose if a woman is responding well without any side effects, and pause there for a few months for her to notice the good, the bad, and the questions, as I usually say in a consult.
Yeah. And are you looking at their blood numbers as well, or it's just a dose, which is, just medium? Yeah.
So when it comes to estrogen and progesterone, I don't do blood tests routinely. I might do an estrogen level if a woman is on a transdermal therapy. If I've got her on increasingly high doses and it's not touching any of her symptoms, I might then do a blood test to check she's even absorbing it well. It's not very common, but occasionally you might find someone who doesn't absorb their estrogen well through the skin and their blood levels are really low. But it's not a routine thing. I wouldn't do that very often. Yeah.
And that would be a really unique scenario where it was being blocked in absorption and just not making its way into
That's
blood at all.
right. They might be putting lots and lots and lots of gel on their skin and they're just not getting it into their system to have any effect. But then we do blood tests for one hormone, and that would be testosterone.
Yeah, let's talk about that, because this in recent years has become a very hot topic, and it might surprise many people that testosterone has been studied in women for 20-ish years, and Australia has led the charge here. But it's been primarily for hyposexual desire disorder, and in Australia it's approved for this. But in my world of health and fitness, a lot of women are wanting this as an agent to help training, recovery, muscle mass, libido, you name it. I think it's being now offered as the elixir for health. And
Yes.
as always, the truth is usually somewhere in the middle. But what I want to discuss with you is its twin uses in libido, but also for the other non-libido aspects, which we're interested in for aging women, which of course is their muscle and bone.
Yes, I think this is a really interesting area. And I'm really excited to see some more studies come out. So as you said, it has been studied, but there's not a lot of randomized controlled trials with placebo-controlled randomized controlled trials for us to make firm recommendations. But as you said, it has been shown to be helpful for low libido. The studies would suggest that 60% of women who have low libido that bothers them after menopause will have improvement in libido on testosterone therapy. That's what the studies show. But when it comes to muscle, bones, mood, and cognition, these areas are still being studied. So there are cohort studies and surveys that do show improvement in cognition as well as libido, and lean muscle mass, and even I think there was one that showed aerobic endurance. So there is some second tier data to support the use of testosterone in these ways. And I think we should be open to considering it, but it's hard to strongly recommend it until the data is more robust. I do have patients on testosterone who come back after a 6-month trial and say, "Oh, didn't do anything for me." And then I've got other women who come back at 3 months and say, "This has changed my life. I'm going to the gym more often. I feel so strong. I feel like myself again." They feel like their mood has improved. So I see all sides of potential improvement and not in the clinic. But the data isn't there yet. We're waiting a trial, I think, to come out of Monash, actually, that is a randomized controlled trial, and it's looking at testosterone versus a placebo, and they're looking at muscle strength and bone density, but that hasn't been published yet. I haven't seen it published, so I'm excited to see what they say with that kind of tier 1 data. But yeah, Tony, I think it's a really interesting area. I think there's biological plausibility that it could improve aspects of endurance and strength, but we want to see it in the studies before we promote its widespread use, I suppose.
And I think this is where it gets really nuanced, because when we look at the decades of research we've got in men on testosterone replacement therapy, there is many studies that are randomized control that are underwhelming. But when you look at the methodology and the results, you can see that the dose of testosterone being used didn't really move the needle very much, or there was not an exercise component. And we really do need those, as we were talking before about supraphysiological dosing of testosterone and exercise to see a difference. And we need these studies in women to have confidence in its prescription. But you're somebody who is prescribing it. In fact, the group that I send my patients to, which you're a part of, I was so pleasantly surprised that this was an option for women to have testosterone prescribed for them, because in many parts of the world, it really isn't. And I was surprised to see the changes in my clientele when they started taking it, because again, I've seen these people for years and decades, and there is a clear change, inflection point upon initiation of testosterone at the higher level and their change in lean body mass and strength.
Tony, I want to see your data published. That'd be great if we could see these patients, because that's really encouraging, isn't it? Because you're seeing it in your actual practice.
Yeah.
But yes, we are using testosterone, and we're trying to replace or improve it to the high level of the normal range for women. So I suppose the question, as you said, is what dose are we supposed to use? What level do we need to achieve in the blood, and at what dose will we see improvement? Because of course the testosterone we use is a cream as well and has variable absorption, so it's not a very easy thing to prescribe. We always have to do blood tests before and check that their total testosterone level is low. Then we give a certain dose of cream and we check the blood tests 2-3 months later and see, is it up to the top of the normal range, which is what is ideal apparently, but that's what we're aiming for, and then continue on that dose. But is that the right dose to help with bones and muscle? I don't know. That's the data we've got from libido. Over time, hopefully we'll answer that question. But we do need to be a little careful with testosterone use in women, because if we go too far above the normal range, we can get side effects that women may find very unpleasant too. So more is not necessarily better. We need to be careful. Women can have increased hair where they don't want it, like their chin, and they can get androgenic alopecia or hair loss from the top of the head, and acne, more oily skin and acne. And I've seen women who have had those side effects and very unhappy.
Are they transient and reversible once testosterone is discontinued?
Yes. Yeah, the studies would suggest that once you stop at that dose and decrease your levels, that the that those side effects will go away. So we are encouraging to those women that it's not permanent. But yes, we need to be careful with the dosing. So that is a blood test we do have to do before and after to monitor effect, not just monitor effect, but monitor blood levels.
And do you have a number that you're happy with when you see a female's testosterone, looking at, say, free and total testosterone?
Yeah, just looking at the total testosterone, the range of normal is about 0.2 to 1.8. And the units that we use in Australia. And I'm happy to go to about 2. Or just over 2 is usually fine. You don't see a lot of side effects. And the other blood test I do is something called an SHBG. It stands for sex hormone binding globulin, and it's a protein that's made in the liver that circulates in the blood, and it actually binds to hormones. So if you have a high SHBG, it will bind to your testosterone and render it inactive. So if you have a high level of SHBG, the studies that we have on libido at least show less of a prediction of improvement or less of an effect, because it's not free to work at the level of the cell where we want it.
Well, there's 2 very interesting things in what you've said there, is looking at the total testosterone being 2, which is just above, as you've mentioned, the reference range in Australia. So I just want all the listeners to realize that you're dosing right up at those upper physiological levels, which is quite remarkable. Yeah. And then secondly, be mindful of the sex hormone binding globulin, because you might have a high total testosterone, but 96-ish% of that is bound to the protein carrier, and therefore there might not be a lot that's available to interact with the androgen receptor. And that's worth knowing.
It is, yes. And if we have a really high binding globulin, we don't really know what happens if we then push the total testosterone higher. Logic might tell us that, if you've got a high binding globulin, you could push your testosterone to 4 or 5, but we don't actually know that. So it sort of just restricts it restricts the benefit of it if the SHBG is high, and our encouragement to use testosterone if a woman has a high SHBG. But we don't really know what to do if we push it higher. We don't.
How often do you see it, though, being a problem?
Probably about 1 in 5 patients I would see that have an SHBG that is above the normal range. It could be from many reasons, but I think some of my patients are on a lot of supplements, and I think that is stimulating the liver in some. And one of the things I do is get them to, if they do have a high SHBG and they're on a shopping list of 12 supplements, I say, can we look at which ones you think are really doing you benefit? Which ones do you really need? Can we pare these down a bit? And then do that for a few months and then repeat it and see if the SHBG is still high. And I find that a bit hit and miss. Sometimes it's a bit lower and sometimes it's still high and I'm wrong. But we do know SHBG is increased by a few different types of conditions, but also the use of oral estrogen does increase your SHBG. So if your hormone therapy, your normal CHAR-T, MHT, is estrogen and progesterone, and you're using an oral estrogen, that increases your SHBG. So if it's high and you're on oral estrogen, you might consider switching to a transdermal form of your estrogen so you can get your SHBG down to be able to get the full benefit of your testosterone if that's what you're wanting to achieve.
Yeah, that's a great point. Let's now turn our attention to sleep, which is another one of the issues of disruption during menopause, which could be just simply related to vasomotor symptoms and feeling hot and having the night sweats. And there can be other causes of disrupted sleep. As a coach, this is one of the biggest areas that I navigate with my females is sleep hygiene and really trying to improve that to get more energy out of a training session. And I think that's a strong reason why we see in the literature an abrupt change in power and strength across the menopause transition is poor sleep. Is there options that you have with your patients from magnesium to medical compounds? How do you approach poor sleep around menopause?
I think asking exactly what the sleep is like is important. So is it that the sleep is being disrupted? What's waking you? Is it your environment? Is there a cat jumping on the bed? Is it a partner snoring? Is it your bladder waking you up? Is it a hot flush or a night sweat waking you in a pool of sweat? Or is it your anxiety that's keeping you up? So trying to figure out what it is that's disrupting the sleep, and also looking at sleep hygiene to see what their usual habits are as they approach bed time is really important. If the sleep is disrupted by symptoms like night sweats, then that's a pretty easy fix in my experience, because the use of an estrogen-containing HRT or MHT will usually improve that once we find the right dose. So the studies look at sleep and menopause show significant improvements, but it's usually tied to night sweats. The other thing, if it is their bladder, because as you go through menopause, the drop in estrogen also affects your bladder and vaginal symptoms. We call those the genitourinary symptoms of menopause. And one of those bladder symptoms is more increased frequency, meaning you need to go to empty your bladder more often. And that might mean that where you, in the past, you might not have needed to go to pass urine at night, now you're going 2 or 3 times and it's waking you up. If that's the case, then it's usually relatively easy to help with topical or vaginal estrogens. So that might be the focus. So those 2 things are pretty easy to help. Anxiety, a little, in my experience, if it has been a hormone very much tied to the hormone change and MHT has helped with their mood, then that may improve too. But I do see a small group of women that no matter what I try with their hormone therapy, their sleep does not improve. And it just shows how complicated sleep can be. One of the type of body identical hormones we give now with estrogen and progesterone, the body identical form, actually we take it at nighttime because it has a little sleepy side effect. So it actually helps calm women and makes them a little more relaxed and can help some women sleep. So sometimes you just get a side effect of the progesterone helping sleep as well. So they're the sort of approaches I would focus on. Then outside of that, none of that's working. And I've still got someone who's struggling with their sleep, and they've got excellent sleep hygiene with attention to screens and caffeine and meals and exercise, and they're doing all those things. Then, some people do use magnesium. Some people do use melatonin. I think the studies are a little hit and miss, but I have seen recently a study on a type of magnesium I'm sure you would know about, called magnesium L-threonate, that has had some benefit in sleep. And they were people who were using an Aura ring, one of these fancy little things, and they had sleep scores that improved with the magnesium from the patients doing a survey, but also from the objective data in their Aura ring. So I'm interested in that magnesium, but I mustn't say that I am an expert in it.
Yeah, I think we all just await for the price to come down because it's still on patent.
I know. I looked it up after I read that study and just thought, wow, I don't think I'll bandy it about too much with my patients yet.
And finally, options for females where there's been a change in body composition. And the literature says what most people experience, and that is the weight didn't particularly go up during menopause, but it shifted. And it shifted to belly fat or visceral fat. And as any medical professional knows, that this is not the kind of fat that we want for its pro-inflammatory and pro-oxidative issues. It's a health nightmare.
Yeah.
Medical options do you have when people do notice a shift in their body composition?
It's so tricky. I would say for most of my patients, it's either the number 1 or number 2 complaint is their change in composition with their belly. We know from all the old HRT trials that the women who were in the control groups, they put on weight and it was more around their tummy off hormone replacement. But hormone replacement has not been shown conclusively to reverse that. I have some women who say it helps shift it for them, but the studies do not really support the use of HRT for body composition. So again, it comes back to lifestyle, because part of it is the change in insulin sensitivity in our muscles and in our body as we go through menopause. And there are other changes to the basal metabolic rate that happen in menopause that mean that if we go through menopause doing the same thing we used to do, we'll probably put on weight. So I usually ask patients to focus a bit more on strength training to increase the insulin sensitivity in their muscle cells, and I ask them to look at their carbohydrate intake as part of that equation of carbohydrate and insulin interactions. And then I would usually send them to someone like you, to a trainer or a exercise physiologist, to look at really tailoring an exercise program for the individual, because again, their one size does not fit all, and you need to focus on their strengths and their limitations, because we're talking about an older population here that can't do every exercise. I think it's one of the trickier areas in menopausal health, and I don't feel my role is very useful when it comes to hormone therapy in preventing or in treating that weight gain.
Yeah, thank you. That's a very helpful answer. And in terms of the exercise department, that is exactly what we do. We have a muscle-centric focus, but also a carbohydrate reduction until we get the desired result, which doesn't have to be no carbohydrate, but we assess the role of carbohydrate for fuel for training. But we really watched the processed carbohydrates and where they were eating them without realizing it. And just a simple change in the percentage of energy in the diet coming from carbohydrate usually has the most profound changes on insulin sensitivity.
Yeah, I think that's interesting, isn't it? A lot of people are very motivated and may go too far too fast. And so I
Agreed.
have some
It,
patients that go straight to keto and really restricted time eating. And while that might be useful for some people, and I've seen good results, and it's not my area, I think it's a little hard to continue those sorts of diets and that sort of
Yeah,
effect.
we use a phased approach. Essentially, Jonathan Little from Canada developed this, and that is start with 150 grams of carbohydrate a day and post meal walking, then reduce that to 130, and then finally, over now 12 weeks, about 30 grams of carbohydrates per meal, 3 times a day, with post meal walking. And it is a very easy, doable, practical strategy that can improve insulin sensitivity.
Well, I need more information about that from you, Tony.
We can have a conversation.
Excellent. I'd love it.
Final question. Thank you. You've been very gracious with your time. And that's essentially on orgasm health, vaginal health. There's been discussion of vaginal estrogen. There's now even discussion of off-label effects of Cialis and Viagra on orgasm strength. What are your thoughts about therapy for vaginal and orgasmic health?
Yes, so there are, it's very common for women to not only notice a decrease in their libido as they go through menopause, but also to notice some local vaginal changes. And that may be described as more pain with sexual activity, which will impair sexual function because of the thinning and the drying of the skin and the lining of the vagina, but also in less responsiveness because of the decreased blood flow to the area, thinning of the skin, decreased size and responsiveness of the sexual organs. So it's a very common complaint. However, not every woman will raise it with their doctor because they may be a bit shy to talk about vaginal and sexual health, which means that a lot of us just need to kind of probe a little bit and say, what about that area of your life? And that's the onus is on us to do that. We should be doing it. But so it's really common. And my approach has been really to look at whether or not testosterone might be used for libido, but also looking at topical treatments. And the 2 topical treatments we've got now available are topical estrogen, vaginal estrogen, which can be in a cream or a pessary, which has been shown to increase the health of the vaginal tissues and the bladder, increase comfort with sexual activity. But the other one we've got is called DHEA. DHEA is a precursor hormone that in the vagina, when you use it, there's one in the market in Australia. It's a little pessary and it's inserted once a day. And in the vagina, it's converted to estrogen and testosterone. And it only has local effects, but it has been shown to help all of the health benefits in the same way as estrogen with the health benefits, but it's also been shown to increase sexual responsiveness and the structure of the vagina and the surrounding areas. So women in the studies have shown better sexual satisfaction with DHEA compared to just estrogen alone. So if that is a significant part of their history, then I would suggest DHEA. I do not use Cialis or what do you call it?
Viagra. Yep.
My Viagra. I don't use it off-label in women at all. But the other thing that women need to know and it's so common at this age, is that the use of antidepressants like SSRIs and SNRIs actually have a side effect of anorgasmia. So actually the side effect of some of these antidepressants mean that women find it more difficult to achieve orgasm with sexual activity. So got to look at whether they're on these medications as well. Do they need those medications? Maybe they do. Maybe the benefits outweigh the risks, but it could be a bit more multifactorial.
That's very interesting. Just as an aside, virtually every male and female who comes across our doors who is on an antidepressant ceases antidepressants once they start testosterone therapy. And I'm not sure if you've observed a similar trend.
That's interesting. I haven't seen it. I suppose when they're looking at the data with mood and energy, then perhaps it's a good idea. I think if anything, I do suggest when patients are on HRT and they've been already prescribed an antidepressant for their mood in the peri or post-menopause, and I'm starting HRT, at some point, if their mood really does improve, we do consider, well, what about slowly weaning it? Because the antidepressant, while it may be life-saving and really useful for mood for some people, doesn't have any other benefit, and it has a lot of side effects, including the one that I didn't mention before, which is insomnia, right? It also causes insomnia. So whereas HRT, if it's helping your mood, has all these other health-promoting benefits, we think, like if used at the right age, heart health and bone protection. So I would often suggest that if we're on the right track and mood is improved, that we start to wean or consider weaning the antidepressants.
Well, Nadya, thank you very much for your time. Where are you spending your days these days, and where can people find more about you?
So I'm in Sydney. As we said, I'm a clinician and I work both in private and public practice. So I have a clinic that people can find me online. My website is changing at the moment, so it might have a few more babies on it than you might expect. But the other half of my time is in the public sector. So I work in the Menopause Hub at the Royal Hospital for Women, and this is an amazing menopause-focused clinic. It's multidisciplinary, so we have gynecologists and psychiatrists and endocrinologists that all focus on menopause and hormone-related concerns. And our mandate is to look after women with complex menopause conditions, so either menopause after cancer treatments or any kind of cancer treatments, or menopause early under the age of 40 or 45, and women who have complex medical concerns. So this is our remit, as we're publicly funded through the New South Wales government. But if a patient thinks that they may fit criteria, then they should ask their GP for a referral if they've been struggling to get some help.
And what is your website?
You can, I don't think I've ever told anyone to Google me before, but you could Google me on Dr. Nadya Chami at email. What is it? drnadyachami.
Fantastic. I'll put it in the show notes. Great. Well, thank you so much for your time. You have been a wealth of information. It's true that you have a clinician's heart and you see the entire patient and look at all the history and everything that goes into complex decision-making for women. So thank you for your work for women, and thanks for coming on the podcast.
My pleasure. Thank you for giving me an opportunity to get more information out there. It's fantastic.
Thanks, Nadya. Thanks for tuning in to the Stronger with Time podcast. If you enjoyed this episode, please consider subscribing or sharing it with someone who could benefit. For more insights and to continue our conversations, you can find me on Instagram. The link is in the show notes. Until then, I'll catch you next week for another episode.